the next hour, we're going to tell you a little bit about the program that Sunflower is embarking upon, but under the much bigger umbrella of sort of leveling what is food as medicine. What is it? What do we mean when we say that? What's the research behind it? What are the different models? What do we know? What do we not know? Where are the gaps? And our project is just a little part of that, but we want to tell you a little bit what we're doing, introduce to you the federally qualified healthcare clinics in Kansas that are embarking upon this, tell you a little bit about the evaluation, but this is not us talking at you. This is a conversation because we are all starting at the same place together. So this is very much going to encourage Q&A from you as well as us. So I am delighted, and you have a lot of information about her in your packet, both in the e-packet and that packet. Dr. Marianna Wetherill has lots of titles and colleges she's associated with. In a nutshell, what's most important to me, she's from Oklahoma, my home state. How you doing, y'all? But she is one of the preeminent leading experts in the country on this topic. So we are delighted she is here today to sort of tell us a little bit about food as medicine and the evidence behind it.
Great. So wonderful to be with you all. I do acknowledge that half of you have heard and seen almost every slide I'm going to show today, but we decided they would probably be of a nice benefit for everyone just to have the refresher and also that ground leveling as we move into kind of some deeper conversations about, well, okay, that's the evidence, but then how do you actually go into actually implementing these things? So just to give you a little bit of history about my background, I primarily work in the space of lifestyle medicine within the School of Community Medicine and the Hudson College of Public Health at the University of Oklahoma. And lifestyle medicine is really disruptive in its own way because it challenges providers to bring up a lifestyle as actually a treatment option for many chronic diseases. And it also challenges patients to think about how they might become more active in their own self-care. However, my research area of interest is food insecurity. And so how can we bring lifestyle medicine, which typically is reserved for people with income and many resources, how can we use lifestyle medicine to narrow those inequities that we see? So I have a definition here that's from the Aspen Institute. I was very lucky with Trina to work for about a year and a half. It kind of got extended during the COVID pandemic to work with a national group of researchers on, what really is food as medicine? Where should the research go? What do we need in terms of our evaluation design? What is the current evidence and how can we build on that? And that report gave a nice definition of food as medicine that we've really used to anchor the planning for this process here. And so the definition of food as medicine is that it's a spectrum of programs and services that respond to a critical link between nutrition and health. And food as medicine interventions, they include two things. They include a provision of food that is designed to support health, and they can include things like medically tailored meals or groceries, or direct food assistance, such as vouchers for produce. And then they also have to have some kind of a nexus with the healthcare system. So some kind of provider endorsement, support, connection needs to be made. They don't necessarily have to happen in a healthcare space, but there needs to be some kind of alignment there because that's how the medically tailoring happens. So there are 3 food as medicine models that we've kind of worked through and discussed for those of you who have been on our training and discussion calls earlier this year. The first includes medically tailored meals, which are fully prepared meals. A question that we get often is, well, is this Meals on Wheels? And the answer is not really. Meals on Wheels do provide a really important link for, ensuring people have adequate protein and calories and also that social connection whenever they're homebound, but they're not necessarily designed in response to someone's personalized needs. So medically tailored meals require a registered dietitian to assess a patient and prescribe a therapeutic calorie, protein, macronutrient package and that meal is then designed and delivered to them. So we have a lot of examples of nonprofit organizations who are doing this work, and we're definitely seeing more research exploring that area of how it can be scaled out. The next model that we've talked through are medically tailored groceries. And so medically tailored groceries are more, you might have heard the term a food pharmacy kind of model, where they're kind of looking at a food pantry kind of design, but the foods that are available through medically tailored grocery programs are really designed to support patients in executing some kind of a nutrition prescription to take control of either their hypertension or their diabetes, or possibly lowering their cholesterol. Could be some examples of what a medically tailored grocery package could look like. And so the length of the duration can vary, from just a couple of visits to a longer period of time, depending on what the goal of the program looks like. And then third category is looking at prescription models, where you might just be giving someone a voucher for some produce, and maybe they're going to the farmer's market or to their local grocery store, and they're redeeming that $10 or that $20 for fresh produce for their family. We've also seen a lot of models of federally qualified health centers having a farmer's market in their parking lot, and their patients then can go and visit and access it for no cost. So can you go back one slide, please? So there's a pyramid that we can also really think about how these programs are stacked in terms of intensity. So we have SNAP at the bottom, that's really designed to ensure that people have access to enough food to eat. And then the next step is really designed about addressing key gaps for affordability and accessibility around certain foods, which is those produce prescription models. They require the least amount of staffing and burden on a team to implement, because they're really just administering vouchers and they're getting redeemed. The next layer of intensity are those medically tailored groceries, because they do require a lot more resources and coordination, and they're being usually distributed on site. And then that top are the medically tailored meals. So we would expect to see the greatest amount of impact at a patient individual level with medically tailored meals, right? Because you're giving it all to them. There's no work to be done other than eating the food, but the cost per patient is very expensive. So those kinds of interventions really are reserved best for critical care patients who you're trying to prevent them from getting readmitted into the hospital after they've been discharged, or for a particular transition amount of time. And Trina will talk a little bit about kind of the hybrid model that I think she achieved with meal kits, where it's a step up from medically tailored groceries, but it's not quite yet the medically tailored meals. So next slide. And how are evidence-based diets designed then? This is a really important thing that I think we want to all think about, regardless of if we have a degree in dietetics or not. I know a couple of us in this room do, but we typically start with looking at epidemiologic studies and saying, okay, well, what food or dietary patterns are associated with either developing a chronic disease or not? And what are those relationships after we control for things like income and education and demographics and age? And then usually those kinds of studies give us some idea about potential leverage points diet-wise. The next step then is to do some kind of a randomized control trial, looking at that food or a particular meal plan and seeing, does this actually change what we think that it will change? And then the third stage is then implementing it in real life setting. And does that still make an impact whenever all of those other factors that happen outside of a clinical research study are mucking up the process? So a really good example of this, for those of you who are interested, is looking at the dietary approaches for stopping hypertension, which followed this model exactly. And it was shown to be effective in lowering hypertension to the same degree as initial prescription for hypertension. So 2 epidemiologic studies that I just wanted to touch on briefly. Next slide. great, is looking at associations between diet and diabetes. And the reason why we're talking about diabetes is every single clinic picked diabetes. We didn't tell them to go with diabetes, but they either are focusing on diabetes or on prediabetes as a part of their food as medicine patient population. And so there's just two studies that I pulled out of the literature to share. This first one was a 20-year cohort study that was comprised of nurses and all women, and they followed them. They did not have diabetes at the beginning of the study, and then they followed them to see who developed diabetes over the course of those 2 decades, and what were those lifestyle factors that could be connected to that diabetes risk. And they actually identified 4 elements of diet that appeared to be the most explanatory. And the first was really looking at unprocessed whole grain foods. So people or women who had the highest levels of whole grains relative to women who did not have intake of whole grains had a lower risk of developing diabetes significantly, which is what that first box up there in the figure is showing you. They also found that women who had more unsaturated fats relative to saturated fats in their diet had a lower chance for developing diabetes. So having more olive oil, canola oil, and saturated types of oils relative to solid fats like coconut oil and butter and things that are more solid fat at room temperature. They also found that trans fat intake was significantly increased chances of developing diabetes. So that's found in things like stick margarine, coffee creamer, powdered coffee creamer, and then glycemic load, which is huge. So what's the potential of the person's diet in causing higher blood sugar spikes after meals. So that's usually tied to having a more processed food diet. So that's a pattern epidemiologically that we found that's connected to diabetes risk, at least in women. And then another study, next slide, looks at diet more deeply and cardiometabolic mortality in the United States. And in this analysis, they concluded that about 45% of all deaths related to heart disease, stroke, and diabetes could be attributed to certain elements of the diet. And the top contributor that they found was actually sodium, which should not be surprising since it does significantly increase blood pressure and can speed up progression of a lot of things. But some of the other things that they found did kind of surprise me some. For example, nuts and seeds. And not eating them, so to speak. So having a diet that does not have nuts and seeds contributes more to risk for heart disease or cardiometabolic deaths than fruit. They're not eating enough fruit. So there's a lot of opportunities within the diet beyond just fruits and vegetables. They're good for us, but there's other food groups that therapeutically, at least on a population level, could really help to shift cardiometabolic mortality if we could help to correct some of those gaps. So the guidelines for diabetes have been updated. They're usually updated every year. I just pulled out some quotes from some of those publications. And so one of the consensus statements said that people with diabetes and those at risk for diabetes are encouraged to consume at least the amount of dietary fiber recommended for the general public and increasing their fiber intake, preferably through food, including vegetables, pulses, beans, peas, lentils, fruits, and whole intact grains to help modestly lower A1C. There is also a lot of debate, depending on what scientific circles or medical circles you're in, about which diet is actually best for diabetes. Is it ketogenic, paleo, carb counting? And the consensus right now is that there is no consensus. Everybody is different. But just take a step back and say, well, what are a lot of those similarities in all of those meal plans so that we can all be speaking the same language and get people at a starting place that's best for them? And so this statement I really liked was talking about, next slide, emphasizing non-starchy vegetables as the base of the plate, minimizing added sugars and refined grains, and choosing whole foods over highly processed foods whenever possible. So those 3 kinds of talking points, and working with patients to achieve that in whatever way they choose to, and starting with what they feel the most confident in changing. Next slide. So I absolutely love this image here, and I use it in a lot of my presentations because oftentimes we give people the ladder on the right, right? It's like, take these big leaps with very minimal support, and if you could climb to the top, you'll be successful. And most of the time, including even probably everybody in this room, if we set that bar too high for ourselves, we really cannot get there. We got to start with small baby steps. So in general, from my experience and based on what the literature says, particularly also working with people who have very limited resources, nutrition prescriptions work best obviously whenever they're evidence-based. So we want to be recommending foods that we feel very confident as healthcare professionals are going to make an impact. When the patient chooses where they want to start, so give them 3 or 4 nutrition prescriptions that they have a choice of implementing, and go with the one that they want to go with, and keep those steps very basic and small. So we've also gone over, next slide, components of a nutrition prescription. How should we be articulating those to patients, recognizing that most patients do not have access to a registered dietitian. They're not going to be able to have 5 sessions of medical nutrition therapy, which is usually what's recommended for patients with diabetes. But how can all people on the healthcare team be saying the same message that's going to be good for most people? And it's being very clear in the type and the amount and the frequency of how these foods should be consumed, and then letting the patient kind of decide and working with them to figure out a way to get there. So I have just a couple of examples up here that probably look familiar to those of you who have gone through our noontime sessions. But for example, vegetables and fruits. Talking to patients about that, having at least 2 varieties at a meal, at all meals per day when possible, and what could implementing that kind of a nutrition prescription look like for you. Maybe we start with 1 meal and work up to multiple meals. Pulses are, I think, remarkable foods because they can quickly address resistant starch and fiber intake gaps that everybody has in the United States pretty much, and they are very, very cheap. The nice thing about these little guys is whenever they get metabolized in the gut, our gut bacteria produce short chain fatty acids from these foods. The short chain fatty acids enter our bloodstream, and they tell our liver to stop releasing sugar. And so there's actually some very remarkable things that these foods physiologically can do for us that we may not be able to get through other foods as well. And in terms of economics, they're great. So half a cup per day is what we're really trying to strive for. Barley and oats are, 2 highly therapeutic intact whole grains. Pretty inexpensive too. They've been shown, especially barley, whenever you replace rice or wheat products with barley, that you actually have a much lower postprandial or after meal blood sugar response. And there's actually carryover benefits even into the next meal if you ate barley the meal before. And next slide. And then nuts and seeds. So working to incorporate a handful of nuts and seeds per day. Not only can they really help with satiety, they have very minimal carbohydrates, a lot of fiber, healthy fat, healthy protein. They're checking a lot of boxes. And surprisingly, they don't contribute to any weight gain. And for some people, they might actually help with a negligible amount of weight loss. So that's a good benefit. And then, we talk about negative nutrition prescriptions in lifestyle medicine. I'm trying to frame this as a positive one of drinking more, but we know that having 1 to 2 sugar sweetened beverages a day increases risk for diabetes by 25%. So if we can get patients to stop or at least cut back in major ways on their sugar sweetened beverages, that's also a really good opportunity point. And talking to them about ways that they can get hydration through sugar-free forms such as water. I know you had like 5 options of fruit water back there that you could try, as well as unsweetened tea, and even, black tea. Yes, I noticed the V8. I had one. It's delicious. I saw at least somebody else got one too. Okay, next slide. So how much does this cost? I was asked to talk about cost. Doing all three of the lifestyle prescriptions that I just went over, the seeds, the beans, and the barley, implementing all of those is 70 cents a day. So this is definitely something that can be done affordably if people have the confidence in how to incorporate them. Next slide. And fruits and vegetables do cost a lot more though. So although we know that they can be very therapeutic, we're looking at closer to like $2.50 per day, low cost to be able to implement those. So I've gone over four prescription options for you, in addition to talking to people about the sugar sweetened beverages that they're consuming that are very economical to implement for the most part. Next slide. We don't have time to go over all of these things, but I really do want to direct you to the Food as Medicine Research Action Plan that's available. And I think it's probably been shared perhaps, and maybe could be shared again, just really summarizing the evidence of whenever these programs are designed well and address multiple nutrition prescriptions within them for diabetes specifically, they can really move the needle significantly on not only food insecurity and what people are eating, but on a number of outcomes related to diabetes self-efficacy, A1C, and other health-related episodes. Okay, I'm concluding with the gaps, and then we're going to move in to explore that a little bit more. Major gaps that I am very optimistic about this process helping us to all learn about. Again, like the failing forward and using that learning to help us figure out how to do this well. We need to know what's the intensity, how much assistance works best and for how long. We need to know, depending on how sick a person is at the start of a program, does that degree of control or not play an impact on how quickly or not they respond to the intervention? And then how do we promote long-term adherence? We can't be a food pharmacy for everybody forever, so what can we do at the end of the intervention period to really help to sustain that permanent ongoing change? And then a million gaps about implementation science, which this team is going to do a remarkable job, I think, leading us through and trying to unpack all of that. So I'm sorry if I'm over on time.
You're absolutely fine.
Okay.
We can switch to the next slide, and Brandon's going to take the stage and talk a little bit about this in Kansas. 2 housekeeping items. The research action plan, you have the executive summary in your packet, and that has the link to the full, 121 pages. Beautiful report. It's definitely worth downloading and reading. We've gotten a couple questions in the chat box about these slides. I apologize for not mentioning that in my housekeeping. All of our speakers have graciously agreed to allow us to share the slides in PDF format. So I'll either be emailing them out afterwards, or I probably will need to put them, don't hate me, on a Google Drive so they'll all fit, and then you can access them that way. So sound good? Okay, so I know those were beautiful, informative slides that we're all going to want to go back to.
All right, so we are doing a stage change here and transitioning to our next session. So while that's going on, I wanted to talk a little bit about kind of the journey that we've taken over the last 1.5 years to move into the food as medicine space. And if you can tell by listening to Dr. Wetherill, and you'll hear from the rest of our folks today, like they're very persuasive. I would say over the last year, we've got more V8 and seeds in our office suite across the way than you can shake a stick at. I mean, I remember hearing one of my kids say, "Why is Dad talking so much about barley?" And I feel this need to incorporate barley more in my diet now. So I think as you go through this process, you will kind of, that will rub off. So Elizabeth and I started working on this about 1.5 years ago through a series of a lot of conversations over Zoom, over phone, few in person at the time that we started this. And those conversations were with a lot of different entities and individuals here in Kansas and across the country. Funders related to the topic, we talked with our funders here in Kansas, Kansas Health Foundation and Health Forward. We talked to other funders across the country. We talked to researchers, food banks, other payers, and we talked to other healthcare systems across the country that were working in this space or interested in this space. And one of the big takeaways for us in that work, as we especially looked at the healthcare systems, is a lot of the healthcare systems nationally that were really deep into this work were systems that we categorized as closed systems, meaning they were both the provider and the payer in one. And they were doing great work, but that was a very safe space for them to operate in. So as we thought about, well, what would food as medicine look like in Kansas? It wasn't going to operate in a closed system. It was going to have to operate with a variety of clinical settings in urban areas and rural areas, in different communities that had access or limited access to other resources and external kind of wraparound support. So it was a little bit daunting to think about what food as medicine could look like in this space. But I think as we connected with Dr. Wetherill and Dr. Bridges and Dr. Harvey and others, we also began to recognize that the work that could go on in Kansas could help fill a gap in what we know nationally about food as medicine. That gap in the literature base of exactly what does doing food as medicine in kind of the open prairie of our state look like, with lots of different players and lots of different clinics in lots of different communities and geographies. And so that is both an opportunity, but it's certainly also a challenge, and a challenge that we've been embracing as we move through this process. So in getting kind of engaged with clinics across the state, we reached out to a number of clinics and had just general conversations about their interest in this work, and kind of would they be interested in moving into this space from a planning perspective. And we found 7 really innovative federally qualified health centers that were eager to jump in with us to think about what this might look like within their community. So we started a 4-month planning process that began in February of this year. And between February and May, we met almost weekly, which was a really heavy lift for clinics. And they were all there every week. Some weeks we had just open office hours, as we called them, where we would have kind of collective conversations about what was going on, questions that they had as they thought about this. Other weeks we had more formal presentations by researchers and other guests from across the country that would talk about food as medicine in their part of the world and what they were learning. And we went through all of the usual suspects of logic models and concepts and all of the things that, are overwhelming, but really helpful when you kind of get to the end of that process. And one of the things that we also spent a lot of time doing, I think, which was really beneficial, and you heard Trina talk about this earlier, was we really asked clinics to spend time talking to their providers, but probably more importantly, talking to their patients. What did they want this to look like? Why would this work? Why would this not work? That was all important to the conversation. So as we ended May, we were ready to say, hey, whoever is still game, would you like to move into what we're referring to as an implementation phase? And so 6 of those clinics said, yeah, the time is right. We feel like what we've learned could be beneficial by actually putting some boots on the ground. And so today is actually our formal launch of the implementation phase, which will support clinics over the next 12 months in this process. But I think one of the things that we've stressed from the get-go is that this can't be a short-term process. And that's one of the things that we've had some long conversations with our board of trustees, which is that this can't be a 12 or 16 month investment and then we move on to something else. it has to be a long-term investment. When you look at other hallmark investments of our foundation, integrated care, for example, is entering its 12th year of investing in that space. Trails is another area that we've invested since the early 2000s. And so I think our board has become accustomed to what we mean by long-term. Long-term is not 3 years. Long-term for us is 10 plus years. And that's sometimes hard to kind of get your head around. But I think that commitment is what it takes to kind of, turn the tide that we're talking about today. So we are really excited to move into this next phase, and we're excited to introduce you to the clinics that will be coming along for the ride.
Oh, I am minus the mic at this moment, but I don't think anyone has a problem hearing me. We're going to transition now into talking a little bit about the evaluation of this program moving forward, but also a big picture conversation of evaluation in general, how decisions are made about what to measure and why, and where are the gaps in the literature. So up here, I'd like to introduce again, we have Dr. Wetherill, who you heard from, also Dr. Kristina Bridges from University of Kansas Medical Center, and Dr. Susan Harvey from University of Kansas. They make up our very robust EAT team. And if it's okay, I'm going to just fire off the first question to you, Dr. Bridges, which is just high level view. Tell us, how the heck are we going to learn anything from this project?
Green means it's on. Okay, thank you. So I have a few slides. Yeah. It looks different than that, but I'll just start. First of all, I want to say I'm so excited to be here with all of you, and I am so grateful to the Sunflower Foundation for bringing us all together and committing to this in the long term. And I think many of you, because you're here, also are committed to this. And I think it's really intuitive to all of us who believe in this, that of course, what we eat impacts our health, and that all these chronic diseases that we see can be addressed by diet. Like, it seems really intuitive. And I love that the point was made so nicely this morning by Trina and by the quote that Brandon shared, that we have these systems that have just been these legacy systems. I like that you said that were kept apart for so long. And then you throw in all of the upstream social, structural, factors of oppression and different things that have put different groups of people with, different access to food and different neighborhoods and all of this, and had, creating all the social determinants so that we all understand how messy the system is right now. And then wanting to bring these two things together and then show some impact on health is going to be really challenging, right? And so then the evaluation of that, the documentation of that is really important to see where we fail, because that's how we're going to learn, right? Did we find the slides? No, I actually have, that's fine. That's fine. I have them here. That's why I brought my phone up here. So I just wanted to talk a little bit about, the reason why we want to document this so carefully and understand as we try to implement 6 different types of interventions in 6 different clinics across Kansas. We brought them all together. We gave them the same education and training, told them the same evidence-based, types of interventions, but then they all came up with different plans, which is fine, because it can't be controlled. If we want it to be, pragmatic and actually work, we have to see what they come up with based on talking to their patients and understanding their needs, and then letting them, move forward with the connections they have and the partners they have. And so we're going to look at this all together. So our evaluation, first of all, is going to be one big evaluation of the 6 different sites, right? And it's important because we need to determine, what works well and what doesn't work. So where where there are failures, and we hope there are failures, because that's how we're going to learn, right? So we're going to gather information on the approach, obviously to share with other places. We want to see what works and see if this can be replicated. And then we need to document the need. Obviously, that's of the patients that you have. We started out our training sessions by asking them to talk to their patients and understand, look through and get patient perspectives. And then it's important for us to document the buy-in of all these clinics and how they can, put it into their workflow, how this is actually going to work if they have physician champions and staff champions and all through the clinic. And then this is going to help determine if this approach is appropriate, right, to replicate. And then I think all of us here are interested in gathering the evidence to make a compelling narrative for us as a state to come together for statewide partnerships, funding from, you know, lots of different sources and maybe some big sources, and understanding how this can be paid for and all the logistics, right? So that's why it's really important to do this. So it was mentioned before that we need to understand implementation. And so when you look at implementation science and research, of course, we're interested in the outcomes, right? So the health outcomes, let's say. Everyone here is looking at diabetic patients and looking at A1Cs. Can we lower their A1C? Well, we know in the literature in different, maybe more controlled settings, yes, giving, you know, patients more fiber and more fruits and vegetables and things will lower their A1C. But does that happen here? And so that's really important. But also the other part that's important is the process evaluation, right? So understanding, did we do the thing that would be effective to make that change? You know, and did we say we were going to do that? Is that how we designed it? And did we actually do those things? And then the other piece of process, which I'm going to let Susan talk more about, is understanding all the people who make up the intervention, right? So we have our patients, we have our clinic and the different roles in the clinic, and really gathering lots of rich data from all of the people that are involved in this. So those are the pieces you have to understand, you know, the design of the implementation, the outcomes that you do see, and then you go back and look at all of the inputs of all of the people and the different resources that we have. Oh, hi. Yeah. Okay, so I'm gonna let Susan talk about process, and I'll go back to, yes, hello.
It's like Christmas morning. I also want to thank everybody here today in Sunflower Foundation. I was frantically scribbling notes as each clinic was talking because I'm interested in understanding those challenges and those successes that each of you, each clinic site has discussed so beautifully this morning. And so I'll be coming out to each of the sites, and I'm really excited about that, and meeting everyone, and hopefully meeting some of the patients as well. And so we'll be collaborating together on the process evaluation. Process evaluation is just how it sounds. We're trying to understand that process. And so trying to understand some of those challenges that each of you mentioned today. How do we overcome that? So if there's staff changes, how does this program become a culture, so that when new staff comes in, it's just that understanding of that this is our culture and this is what we do, so that there's not that big task of trying to retrain somebody after having somebody so long be part of that process and somebody new coming in. What does that look like? So understanding that process. So we're really interested, as we've discussed today, and I think Trina really said it beautifully this morning too, that participant-centered approach, understanding from that participant perspective, perhaps if they, start the program and then maybe don't follow through, which it sounds like some of those areas where they get their prescription and they're in and out of the clinic and, oh, I'll be fine in 30 days. What does it look like from them or from their perspective to adopt this as a lifestyle and to continuing it, but also understanding it from your perspectives as well. What does it take for a clinic to be able to successfully implement this, and then to continue it long term, and then so that we can teach other clinics what does this look like, and how this can and should be done, and that it should be a culture that's just adopted and embraced within hopefully clinics. So I'll be making 2 site visits out to each of the clinics, really trying to understand that environment in which this program is taking place. Just listening to some of you today, we have very urban and we have very rural. And I think this is and I think you brought it up this morning too, just how interesting it is looking at the diversity of these clinics that are taking this on, and understanding what works and what doesn't, who is this effective for? What components, what activities, those cooking classes, are they effective, or do we need to simplify it more? So looking at some of those activities and seeing how effective are they, and who is it effective for, and how can we change it and make it better? But also keeping in mind each of your individual clinic sites as well, that each of you are different and you're serving different populations, and trying to really understand that. So the process evaluation really tells a story. I do want to say, and I think Elizabeth brought this up, this is not an evaluation of clinics. This is an evaluation of the program and understanding what works, the process of it, and how to make it robust and transferable to other clinics, so that hopefully other clinics across the state are able to take the lessons learned that you guys are really pioneering here, and make it work for their clinics as well.
Thank you, guys. Brandon and I have a couple of specific questions, if we may, and then we have some time to open it up to the group. You want to ask the one about decisions?
Sure. So Dr. Bridges, Dr. Harvey have talked about kind of some of the moving parts of evaluation. One of the things that we wanted to make clear was that the clinics can still collect information and explore areas that are pertinent to them. But then there is this kind of overarching evaluation that's applied across all of the sites that will be working in the Food as Medicine project. So tell us a little bit about kind of that decision-making process of how you arrived, or we arrived at kind of that set of core outcome metrics.
Thank you. So again, we looked at the literature and what has been shown, as an outcome of success for Food as Medicine, and that is lowering A1C. These biomarkers here, A1C, blood pressure, and weight, to some degree, have all been shown to be impacted by food. And so we knew that we wanted to look at those. We took in, obviously, the input from all of the clinics of, what patient population they're going to be focusing on, and sort of the outcomes that they were interested in as well. So our biomarkers are those like sexy outcomes that everyone expects to see. Did you make a change? But obviously we want to look at diet quality as well. So understanding, baseline, how many fruits and vegetables or beans or fiber, things are you eating? And then after this, has that changed? And then also cooking, because we'll be giving, most teams are giving raw ingredients that people will be cooking with. And so again, baseline, how comfortable were you with the cooking, or were your skills there? And then did that change? And then the knowledge and utilization. So, do you know about certain resources or where you could get food before? And did you learn maybe from working with the community health worker, for example? Do you now have more information about where to access your food? And then mental health and quality of life came up a lot when talking with the clinics. So we're going to use validated tools to measure that, to see if there's a change baseline to after intervention. And then we're going to be also looking at providers and the physician champions and those in the clinic to understand, from the beginning to the end, what their attitudes were like and their buy-in and how they felt like it went. And then the process.
Sure. So the process measures, there's typically 6 elements that we look at within a process evaluation. So we look at dose, as it was discussed earlier this morning, the frequency, the intensity of the produce, or I'm sorry, not of the produce, but the meals being provided. Fidelity, that's a really fancy word for just asking, was the program implemented as planned? And if not, why not? What were the kinks that happened so that it couldn't be delivered as planned? Just so that we can understand, again, that whole process. We're also just looking at, everybody talked about the recruitment and who the intervention is specific to, but we also want to understand how many people participated, and then, at the end, what did that look like? Were we able to retain all of those individuals if they dropped out? Trying to understand, why did they drop out? Did they move, or was it for other reasons? Maybe because they worked those 10, 12-hour days and just couldn't keep up, and trying to understand from their perspective. And so each site will have monthly surveys, will reduce respondent burden. So it'll be short, quick, easy, because it sounds like staffing challenges are certainly a barrier for a lot of these, for probably everybody. And then I think my favorite part, this is why I'll be on site, is looking at that environment in which this program is being delivered, and really understanding from that urban to rural scale and everything in between. What does this look like from the site perspective, the stakeholders who are delivering the program, to the participants, to the food banks and food pantries that are also a big part of this, really digging in deep and trying to understand what are the successes and what are the challenges and how have you overcome those challenges, and really taking a look at that environment which this program is being delivered.
Great. Next question, Dr. Wetherill. You served on the Aspen Institute's Food and Society, Food is Medicine Task Force for the Research Action Plan. Got it. Okay. Sounds very impressive. Based on that and everything you've seen in the literature across the country, what do you think are some of the biggest gaps that still remain in this body of knowledge? And I know this sounds like a leading question, but will this project at all contribute to that?
Of course it will. So really most of the gaps center around people failing to do this slide entirely, because most of the time funders don't want it. They don't pay for it. They don't care. At the end of the day, they just want to know if A1C changed, right? But the problem with that is you miss out on figuring out really how to, improve a program, what worked, what didn't. Was the intervention the problem, or was it, some of these other areas in terms of maybe the intervention wasn't implemented as it was intended to be implemented? And so I'm really excited about this collective project to be able to fill numerous gaps. So for example, if you look at a lot of the studies that conclude that the food as medicine intervention didn't work and there was no change, you actually look at the foods that were provided and they didn't actually really align with a nutrition prescription for diabetes. Having that kind of information is really important before concluding that a food as medicine intervention didn't work. You have a better understanding of why it probably didn't work. We also always have these best laid plans of, we're going to design, a food box or a food kit that provides these things. But then what happens when the produce truck arrives and half of the produce is missing? That week, people only got half the produce that they were supposed to receive. And so you're diluting down the intensity of the intervention that wasn't intended. So having those kinds of pieces of information, I think, are really important. The other big gap is household utilization. So a lot of these programs have usually been dosed at the patient level, but we all usually share food with the people that we live with, right? And so there's a lot of diluting effects that happen because people do not hoard their foods to themselves, they share it, right? So I think us looking at household utilization, household size, encouraging scaling the level of assistance where we can, so that we have a adequate dose, I think is going to be really, really good part of the element of the evaluation.
All right, thank you. Well, we are butting up against time here, and in an effort to stay on schedule, we're going to open it up to now for questions from the group. Any questions for our panel this morning? Don't be shy. They are not. Yes.
Thank you. All right, so as previously mentioned, it's exciting to hear the challenges just because us as supporters and stakeholders, you need to tell us. So I appreciate hearing that. So then when will we get an update? When do we hear from these folks again? When will we know something again?
That sounds like a question for us, which wasn't part of the deal. Yeah, no, it's a good question. I think that we are moving through the process at the speed of which clinics feel comfortable kind of onboarding. And so while we're calling today a launch, it will take us some time to kind of get things in place for clinics to kind of feel like they've got staffing up to speed. We hope by the end of the calendar year, we kind of have some idea of like where things stand, where with in terms of, you know, are clinics moving in the direction that they felt like that they wanted to move? What are patient engagement? What's patient engagement looking like right now? Enrollment in the process. Susan will probably have done some of her first visits to kind of look at what things look like in the beginning. And so kind of in that mid-course, we'll have an idea of like where things stand. So we'll hopefully be able to provide some feedback at that point as to what we know kind of at the midpoint of the process. Certainly as we approach the end of that, we'll have a lot more information to kind of put out there, but our midpoint will be probably our first point of circling back and taking a look at what we're seeing in the field.
I'm glad you asked that question because the reason you're here today is we want you part of this process from day one. We envision having another collaborative like this in the spring of 2023. Where we all come back together. Maybe there's even new partners in the room, and that will be a natural point to share what we're learning. But if you have thoughts that are going through your head today, partners and stakeholders in the room, please follow up with Brandon and myself about how ways you think your organization might be involved in the future, what resources or support you could bring. That's why you're here today. This is not just a sunflower project. This is a Kansas project. Other questions?
One of the things I was also going to add, and Susan touched on this as well, is, you know, the food banks will be an integral part of this project. So the Kansas Food Bank harvesters, Craig and Brian are here from the Kansas Food Bank, wave. Jessica and Nathan are here from Harvesters, wave. And so the food banks will be working closely with each of the clinical partners as they move through this next year. And they will be part of that evaluation as well. You know, Susan will be talking with them in terms of like what's working and not working on their end as they try and procure food and move it to clinical sites that, you know, what's it look like in terms of wish list and what they can get on a routine basis. And how do you work within the limitations of the system, but also how do we innovate and evolve that system so that it can respond and do more, which I know the food banks are always wanting to do. We're blessed in Kansas with having 2 food banks that are really innovative, and they are continually trying to push the boundaries of the kind of box that they are working in a lot of times. And so I think this project really helps expand that aspect of what we're hoping to learn as well.